Clinical robustness is not a form of treatment optimization. Optimal treatment protocols typically push organ function toward its performance boundary. At that boundary, the physiological distance to failure is zero. A patient can be on an optimal treatment regimen and simultaneously be clinically fragile. Physiological reserve is defined as the gap between organ capacity and current demand. Organ failure occurs when this gap becomes non-positive. Reserve is a distance in physiological state space. It is not a statistical average of patient outcomes. Organ failure is modeled as an absorbing clinical state. Once entered, no future treatment can reverse terminal deterioration. All subsequent patient trajectory is irrelevant. The terminal condition dominates all preceding clinical behavior. When organ capacity and physiological demand both fluctuate, the safety margin becomes a variable quantity. Clinical safety is measured by the probability that reserve remains positive, not by the average value of remaining reserve. The patient's physiological state space is partitioned into viable and failure regions. Long-run disease dynamics drive physiological state toward the failure region. A patient with an absorbing failure state has no stable long-run equilibrium within the viable physiological region. Positive average clinical trajectory does not prevent critical threshold crossing. Tail-driven physiological excursions can reach organ failure thresholds regardless of mean trajectory direction. Clinical safety depends on tail behavior of organ function, not on average expected outcomes. No optimal reserve level can be derived from probability alone. Physiological reserve is a structural object. Robustness is distance from organ failure, not maximization of expected clinical outcome.